So I will share my presentation. Am I audible?
Yes, sir.
Yeah.
Okay, thank you. So before going into the session as such, I understand that you covered basics of pain, WHO ladder, non-opioids, and adjuncts. So can any of you tell me a few examples of non-opioids? Either you can unmute and speak, or you can.
Paracetamol.
Sir, paracetamol.
Yeah, paracetamol. Very good. Any other?
Meloxicam, ibuprofen.
Yeah. So paracetamol and all other NSAIDs are included in non-opioids. So as you said, paracetamol, ibuprofen, diclofenac, meloxicam, all those mefenamic acid, all those things. That is non-opioids. What are adjuvants? So the first step of analgesic ladder includes non-opioid plus or minus adjuvants. So what are adjuvants? Anybody? Okay. So adjuvants means these are medications whose primary action is not pain relief. So medications whose primary action is not pain relief, but is helpful in some painful condition. These medications are called adjuvants. Okay. So let me ask you a question. What is amitriptyline and what is its primary indication?
Antidepressant, sir.
Antidepressant. Yeah. So it's amitriptyline is primarily not an analgesic. It is an antidepressant. But have you seen that amitriptyline being used in some painful condition?
Yes.
Which condition?
For neuropathic pain.
Yeah, patients with neuropathic pain. So you might have seen patients with the diabetes who is complaining of burning pain on both legs. So that's a type of neuropathic pain. So amitriptyline, even though it is not primarily an analgesic, so adjuvants are those medications whose primary action is not pain relief. So here amitriptyline primary action is not pain relief. Primary action is an antidepressant action, but it is helpful in some painful condition. That is, for example, it is helpful in neuropathic pain. So it becomes an adjuvant analgesic. So likewise, there are many other groups of medication which are classified as adjuvant analgesics, which can include anti-epileptic. Can any of you give me an example of anti-epileptic?
Levetiracetam, sir.
Levetiracetam. Anything else?
Heptadine sodium.
Okay.
Valproic acid.
Yeah. More commonly used?
Levipil.
Levipil, that is levetiracetam. Gabapentin, pregabalin. Have you heard of?
That
Okay.
is neuropathic pain.
Yes. So, but the primary action of anticonvulsant is it is used to treat epilepsy or convulsion. Okay. So primary action is not analgesic action. The primary action is anti-epileptic action, but it is helpful to treat neuropathic pain. Then it becomes an adjunct. So I am giving you some examples. Okay. So there are various groups of medication which comes in adjuvant analgesics. So tricyclic antidepressants like amitriptyline, imipramine, all those groups. Anti-epileptic medications, which you have mentioned now. Then dexamethasone, local anesthetics. There are Buscopan, that is hyoscine butyl bromide. What is it primarily used for? Hyoscine butyl bromide, the trade name is Buscopan.
Relieve the abdominal spasm, sir.
Yeah, so it is used to relieve intestinal colic, isn't it? But the primary action is smooth muscle relaxant action. Okay, it is an antispasmodic. So as a result of relaxation of smooth muscles, it will give pain relief. Okay, so primary action is not pain relief. Primary action is antispasmodic action. Okay, so all these are adjoint analgesics. Now we will move on to opioids. Okay. So all of you know that this is the WHO analgesic ladder, and we have described the first step in WHO analgesic ladder, which is used to treat mild pain. And if the patient has moderate pain, you have to use the medication from the second step of WHO analgesic ladder. That is opioids for mild to moderate pain, plus or minus non-opioid, plus or minus adjunct. And if the patient has severe pain, you have to use third step of WHO analgesic ladder, which includes opioids for moderate to severe pain, plus or minus non-opioid, plus or minus adjunct. So can you tell me what are the opioids available in India?
Morphine, pethidine, sir.
Okay. Anything else?
Fentanyl,
Fentanyl, yes.
Codeine.
Codeine, yes. Okay. Opioids to treat mild to moderate pain. Which all opioids can be used to treat mild to moderate pain? So these are tramadol, tapentadol, dextromethorphan. Sorry, not dextromethorphan, it is dextropropoxyphin. Okay, I have written it wrong here. It is dextropropoxyphin and codeine. So tramadol, tapentadol, dextropropoxyphin, and codeine. These are the opioids to treat mild to moderate pain. Or in other words, you can say these are the opioids used in second step of WHO analgesic ladder to treat pain. And opioids to treat moderate to severe pain. This include morphine, fentanyl, and methadone. Okay. And there are many other medications or opioids which you know, which you have used, like pentazocine or that is Fortwin, then pethidine. But these medications doesn't have much role in chronic pain. Okay. So we have a patient who is complaining of severe pain. And he is suffering from carcinoma of the larynx. You can see the pain score is 10 by 10. There is no radiation. And because of this continuous pain, he is unable to sleep. Suppose this patient comes to you with very severe pain of score of 10 by 10. What are you going to do this for this patient? How do you relieve his pain? Anybody? So what is the severity of the pain here? Is it mild, moderate, or severe?
it is severe.
It's severe, isn't it? Because it is 10 by 10. 0 to 3, you can call it as pain score of 0 to 3, you can call it as mild pain. 4, 5, 6, it is moderate pain. 7 and beyond, it is severe pain. So here it is, patient is suffering from severe pain. So which step of WHO analgesic order are you going to use to treat this patient?
Strong opioids.
Yeah, which step?
Third, sir.
Yes, Prince.
Third step, sir.
Yeah, third step, because this patient is suffering from severe pain. So from the third step, you have to use the medication. So which all medication are you going to use to treat the pain of this patient?
Strong opioids.
Strong opioids. What are the medication in the third step of WHO analgesic ladder? It is opioids for moderate to severe pain, plus or minus non-opioid, plus or minus adjunct. So you need to use an opioid. Which opioid are you going to use here?
Sir, morphine, sir.
Morphine. Yeah. Thank you. So how fast, suppose if we are suffering from pain, how fast are we, do we need to get pain relief? Immediately, isn't it? So for this patient also, we have to give immediate pain relief. For that, we have to do something called intravenous morphine titration. So you will give injectable morphine. And this is in titrated doses. This is known as intravenous morphine titration. Okay. So how do you do intravenous morphine titration? You have to give injection morphine 1.5 milligram at every 10 minutes interval. So you give 1.5 milligram, wait for 10 minutes, and then again give 1.5 milligram every 10 minutes. But I'm sure many of you have given many opioids to patients. And what is the immediate side effect that you expect by administering morphine to a patient?
Constipation, sir.
Respiratory depression.
Constipation, respiratory depression, anything else?
Vomiting, nausea, sir.
Nausea, vomiting.
Yes, it is nausea and vomiting. That's what you have to expect with the small dose. So how do you prevent this nausea and vomiting?
Antiemetic, sir.
Which antiemetic?
Ondansetron, sir.
Ondansetron. Okay. So it is usually not ondansetron. You have to give either haloperidol or metoclopramide. Okay. So it is, we usually give metoclopramide. There are reasons for this. So injection metoclopramide 10 milligram IV, followed by injection morphine 1.5 milligram at 10 minutes interval. And now you might be thinking, how many doses should I give, or when should I stop giving morphine? So the answer is this: either the patient should have satisfactory pain relief, or the patient should develop sleepiness, whichever be the first. So you will continue to give morphine until patient has satisfactory pain relief or the patient develops sleepiness, whichever be the first to occur. Okay. And morphine, what is the strength of morphine ampule and how many ml? Any idea?
Naloxone, sir.
15 mg, no?
Yeah, various strengths are available. Some ampules contain 10 milligrams, some ampules containing 15 milligram. So you have to dilute, this is in 1 ml, okay, 1 ml containing 15 milligram or 10 milligram. So what you have to do is take 1 ml of morphine, add 9 ml of normal saline. So that is total 10 ml, which contains either 15 milligram or 10 milligram of morphine. And from this mixture, 1 ml contains either 1 milligram or 1.5 milligram of morphine. That's how you will do this intravenous morphine titration. And while you do intravenous morphine titration, you can make a chart like this, which includes the time, pulse rate, respiratory rate, blood pressure, what is the pain score of the patient, is the patient drowsy or not, what is the dose of injection morphine you have given. So this patient, suppose he came to us at 10 a.m. You asked his pain score. He says, I have very severe pain. It is 10 by 10. Then you checked his vitals. The patient is not drowsy. Then you will give injection metoclopramide followed by 1.5 milligram of IV morphine. Then wait for 10 minutes. At 10:10, you will again ask the patient, what is your pain score now? Patient says, now it is 7. You check all the vitals, then you are looking at the patient. Patient is not drowsy. So then you can give another 1.5 milligram. Wait for another 10 minutes and repeat this process. So you can see that by 10:30, this patient pain score has come down to 1. That means patient's pain is under control. He has satisfactory pain relief. Patient is not drowsy. So we have to stop intravenous morphine titration here. So total how many milligram of morphine has consumed by this patient? It is 4.5 milligrams, isn't it? So after this patient became happy because he got pain relief, and for the last 2 weeks he was suffering like anything, and now he has good pain relief. So he want to go home. So what would you do now? You have to give morphine. So what would you do now?
Switch it over to tablets, sir.
Okay. So what would be the dose of oral morphine?
10 milligram fourth hourly, sir.
10 milligram fourth hourly. So why did you say 10 milligram fourth hourly?
The pain, then only the pain will be controlled, sir.
Okay, here we have given only 4.5 milligrams, isn't it?
So near the dose here, sir, 5 mg for the day.
Okay, thank you. So when we convert a patient from IV morphine to oral morphine, for a patient who was not taking any opioids previously, then you have to use a 1:1 ratio. That means intravenous morphine, whatever be the dose of intravenous morphine that you have given to the patient, you can directly give that dose as the oral dose. So this patient received 4.5 milligram. So you can give oral same dose, that is 4.5 milligram, but it is not practical to give 4.5 milligram as we have only 10 milligram tablets. So maybe you can give 10 milligram half, that means 5 milligram. Okay. So this is how you have to give oral morphine. You have to give it every 4 hourly. That's the duration of action of morphine. So morphine has to be given every 4 hourly. This is one of the important thing because many healthcare professionals will, when they see that the patient is on morphine, they will ask the patient, whom did you tell to take this every 4 hourly? Don't take this every 4 hourly. But the fact is that the morphine has to be given every 4 hourly. Okay. So here this patient received 4.5 milligram of morphine. So we are giving 5 milligram, that is tab morphine 10 milligram half every 4 hourly. So instead of when the patient wakes up, you can say it is at 6 a.m. half, 10 a.m. half, 2 p.m. half, 6 p.m. half, and at 10 p.m. it is double dose of regular. That is, instead of half, you give 1. That is 10 milligram. So this is how you have to administer morphine. And you can also give SOS dose of morphine. Whatever be the regular dose the patient was taking, that needs to be administered as SOS dose. So the patient was taking 20 milligram of morphine every 4 hourly. What would be the SOS dose?
Ten milligram.
10 milligram? Patient was taking 20 milligram of morphine every 4 hourly. It should be 20. Okay. If the patient was taking 50 milligram of oral morphine every 4 hourly, the SOS dose is 50. Okay. I hope you understand this. And if you do not have injectable morphine with you, and many of the palliative care units may not have injectable morphine, they have only oral morphine. So, in such case, if for the patient whom we have discussed, we have to start with morphine 5 milligram. Okay. And 5 milligram every 4 hourly with a SOS dose. But if the patient was taking weak opioids like a codeine or tramadol or tapentadol, you can directly start with 10 milligram every 4 hourly with SOS dose. So here, now our patient, we started him on morphine 5 milligram every 4 hourly with SOS dose. And he was having very good pain relief for the last 2 weeks. But then his pain increased and he started taking SOS dose. He was taking 3 SOS dose of morphine per day for the last 4 days. And do we need to do anything with the dosage of morphine now? Any idea? So this patient is taking SOS dose in addition to the regular dose. What does that mean? The regular dose is...
Pain is not relieved, sir.
Yeah, pain is not relieved with the regular dose. That's why he is taking additional dose. So this means you have to increase the regular dose of morphine. Okay. So what is the indication to increase the dose of morphine? If the patient is taking 2 or more than 2 SOS doses, you have to increase the dose of morphine by 30 to 50% every 24 hours. So if the patient is taking more than 2 SOS doses, you can increase the dose of morphine, okay, by 30 to 50%. And how frequently we can increase the dose of morphine? Every day you can increase. Okay. So our patient was taking 5 milligram, and if you take 50% of 5 milligram, that would be 2.5, isn't it? So this patient, you can give 7.5 milligram every 4 hourly. But I don't know how many of you have seen morphine tablet, a 10 milligram. It's a very small tablet, and breaking it into 4 pieces is very difficult. So in such cases, even you can increase it to 10 milligram, 5 milligram to 10 milligram. Okay, now sometimes patient might ask you, you told me that I can take SOS dose of morphine. How many times can I take? What would be your answer? Anybody?
If SOS dose becomes equal to a day's total dose of the day.
Okay. So we need to understand something about morphine pharmacokinetics and morphine pharmacodynamics. Okay. Then only we can answer this question. So you can see this is the poppy plant or opium plant. The scientific name is Papaver somniferum. And this poppy plant is legally cultivated only in 3 states of India. That is UP, MP, and Rajasthan. Okay. And the farmers, you can see the poppy fields like our paddy field. And the seed-like things is known as pod, pod. And you can see the farmers are making small cuts on the pod, and from that the sap is coming out, which will be collected by farmers. They will dry it in sunlight, and this will be transported into government opium and alkaloid factories, where they will make morphine powder out of it. And then this morphine powder will be transported to various pharmaceuticals, where they will make morphine tablet, capsule, injection from this. Okay. So regarding absorption of morphine, it is absorbed from the upper small intestine. And morphine is hydrophilic. That means it is water soluble. And some of you might have heard that you can administer morphine sublingually or just keep it buccally or gingivally. But this is not indicated. Sublingual or buccal or gingival absorption is very low. So morphine should not be administered through sublingual, buccal, or gingival route. And it is also bitter. So if you powder the morphine tablet, remember to sweeten it with sugar or fruit juice. Otherwise, it would be bitter. And what happens if you swallow the morphine? It goes into the GI tract. Then it is absorbed into the blood vessels of the intestine, from where it will go into portal vein, from portal vein to liver, and in the liver metabolism takes place. Okay. And metabolites are liberated into the systemic circulation. So morphine is metabolized in the liver, where metabolism takes place, and these metabolites are liberated into the systemic circulation. And this metabolites will give you the pain relief. So it will take some time, isn't it? And what happens to morphine? It is converted into various metabolites. But mainly there are 2 metabolites which are known as morphine 3 glucuronide and morphine 6 glucuronide. Or in short form, it is called M3G and M6G. Here M3G is formed in high quantities, whereas M6G in small quantities. But M6G, which is formed in less quantity, is the metabolite which will give you the pain relief. Whereas M3G doesn't have much action, but it might contribute to neurotoxicities of morphine. So M6G is the metabolite which will provide pain relief. So morphine has to be swallowed. It has to go into intestine, absorb, goes to liver, where metabolism takes place, and metabolites are liberated into systemic circulation, which will provide pain relief. So this process will take some time. So morphine will take about 30 minutes to start getting pain relief, and the peak action would be by about 1 hour. So what would be the answer for this question? How frequently should you give SOS dose of foreign morphine if needed? How frequently can we give SOS dose? Anybody? So the peak action of morphine is by 1 hour. So when somebody takes morphine, suppose patient took morphine at 6 a.m. By 6:30 a.m. patient says, my pain is not relieved. Would you give morphine to that patient?
No.
Then when would you give morphine?
After 1 hour.
Yeah,
After
at
1
7, yeah, at 7 o'clock. So that's the answer here. How frequently would you give SOS dose of oral morphine? Every hourly you can give SOS dose of morphine. Okay. So now the patient, his morphine dosage was increased to 10 milligram every 4 hourly. But patient says it is very difficult to take every 4 hourly. This is very much true, and you might have seen many patients, they are not taking medication properly because they have to take it very frequently. But the patient says, if you are willing to give less frequently, I can take it. So what would you do in this patient now? What can we do? Okay, so I told you that the duration of action of morphine is 4 hours. That's why we have to give morphine every 4 hours. That morphine is called immediate release morphine or fast acting morphine. But we also have something called sustained release morphine or controlled release morphine. Okay, the duration of action of sustained release morphine is 12 hours. Okay, so for this patient, we can actually give sustained release morphine. So what would be the dose of sustained release morphine that you are going to give this patient? Can you calculate? What is the total dose of morphine this patient is taking?
$60 mg now.
60 mg. So if you convert this into sustained release morphine, what
30
would be
mg
the-
SRBD.
Sorry?
30 mg SRBD.
Yes, 30 mg SR BD. Yeah, that's it. Okay, there is a power failure here, but I will continue to talk. So we have to give sustained release morphine. Duration of action, as I told you, it is 12 hours. So 30 milligram BD, sustained release morphine. But this patient can have pain in between, isn't it? This patient also need to take SOS dose. Then which morphine would you give? What would be the dose? You have to give immediate release morphine or fast acting morphine. The dose would be 1/6 of the total dose of morphine. That is, this patient is taking 60 milligram, 1/6 would be 10 milligram. So if the patient has pain in between, you can give immediate release morphine 10 milligram. And what are the preparations of morphine available? We have aqueous solutions or syrup. Yeah. Tablets and capsules, both immediate release and controlled release. Then injection. The strength of injections amplitude may vary. So our patient now is on 10 milligram of morphine every 4 hourly for the last 6 months. And then one day, this patient was brought to casualty with excessive drowsiness. On investigation, you see that total count is 13,000, blood urea 20 milligrams per deciliter, serum creatinine of 5 milligrams per deciliter. Okay. So, what is the reason for this excessive drowsiness in this patient? Can you think of any?
Drug toxicity.
Sorry, Leia, I
Sir,
couldn't.
he got a
Drug
renal
tox.
failure, sir. Due to that, uremic encephalopathy happened, sir.
Sorry, it's not very clear. Couldn't the well.
Sir, he got renal failure, sir.
Yes.
Since the 5 milligram of creatinine, that's why he got a uremic encephalopathy. That's why he is become drowsy, sir.
Okay.
We can write it. We can write the like yesterday's no. Russell tell it about.
Prince, are you telling something? Okay. So what you have to understand is morphine is excreted from the body by glomerular filtration. That is by kidney. Okay. So what happens if the patient has renal failure? Here, serum creatinine is 5 milligrams per deciliter, which indicates the patient has deranged renal function. So what happens is whatever you are administering, whatever morphine you are administering to the patient is not going out from the body. So morphine and its metabolites get accumulated in the blood, which will cause toxicities of morphine, which includes severe drowsiness. So that's why this patient becomes very drowsy. Okay. So what can you do in such condition? You can withhold 1 or 2 doses of morphine till the patient becomes alert, and then you start with a lesser dose of morphine and give it with a wide spacing instead of 4 hourly. Or you have to give alternate renally safe opioids. So in this patient, you can give morphine 5 milligram 8 hourly instead of, he was previously on 10 milligram 4 hourly, but now we have reduced it to 5 milligram 8 hourly. Okay. So now this patient is at home and he was taking it regularly, 5 milligram 8 hourly. But after about 2 months, this patient was unable to swallow anything, including water. Probably this patient is at the end of life, and that's why he is unable to take anything orally, including water. So what will you do now for pain relief? If the patient don't take morphine, he is going to get severe pain. So how do you give pain relief for this patient now?
IV administration.
Okay, IV. Yes. But how many hospitals would allow the patient to take injectable morphine to home?
Through rights to feeding, we can administer, sir.
Okay, so Priya want to put a rice tube and feed the patient. Anybody else? Okay. What are the routes through which we can give morphine? Prina Patel says patch. There is no morphine patch.
Subcutaneous,
Yes, subcutaneous.
orally,
So
IV,
most
rectally.
common route is oral, followed by intravenous or subcutaneous. Any other routes? You can administer morphine rectally. Okay. And epidural, intrathecal, and even intramuscular administration is possible. But what is the most common side effect of intramuscular injection? Most common side effect of intramuscular injection? As nurses, you should know this. What is it? Most common side effect of intramuscular injection? Many of you might have children, and if you call them to take vaccination, would they come with you easily?
Highly painful.
Sorry, Agnes?
Painful, highly painful.
Painful.
Nerve damage. Nerve damage will cause the blood vessel.
Yeah, it's pain. Most common side effect of intramuscular injection is pain. Why are we giving injection morphine? To reduce the pain. But if we are going to provide injection morphine by intramuscular injection, you are adding to the pain. So that is one reason. And another reason is that after intramuscular injection, the absorption of morphine is erratic. So these are the two reasons why morphine is not usually administered intramuscular. So for the patient, we discussed which route would you select now?
Sublingual.
I told you sublingual, gingival, or buccal route. Morphine is not absorbed properly.
Corrective.
Corrected.
sir.
Yeah, corrected. Because I already told you that morphine is hydrophilic, that is water soluble. So you can take the morphine tablet, add 2 drops of water, make it a paste, do a rectal examination, and just deposit this paste in the rectal mucosa. That will give you good pain relief. So this patient who was taking morphine 5 milligram 8 hourly, we can give the same dosage at same duration of action. So 5 milligram 8 hourly, it has to be administered correctly. 5 milligram per rectal every 8 hourly. It will give you the pain relief which he was getting when he was taking morphine orally. Okay, now we are moving on to another patient. A 55-year-old lady with carcinoma of the colon who is complaining of abdominal pain, which is continuous, and she is on 10 milligram of morphine every 4 hourly, and she has very good pain relief, not taking any SOS dose of morphine. And here also the patient says it is very difficult to take it every 4 hourly. So the treating doctor has asked this patient to replace the morphine with 25 microgram of fentanyl patch. But next day, this patient comes to your OPD and tells you that I removed the fentanyl patch. I removed the fentanyl patch after 5 hours of application, as she didn't have any pain relief. So what are you going to do for this patient now? Anybody? Okay. So we have to understand some basics about fentanyl. So transdermal fentanyl patch. What happens is when you apply fentanyl patch first time on a patient, it will form a subcutaneous tissue depot or subcutaneous tissue storage. And for this subcutaneous tissue storage to occur, it will take about 8 to 12 hours. It will take about 8 to 12 hours. And once this subcutaneous tissue depot is formed, then fentanyl will be gradually liberated into the systemic circulation. So that means till 8 to 12 hours, the patient would not get pain relief. Okay. But what happened in this patient? This patient removed fentanyl patch after 5 hours of application. That's why patient didn't have pain relief, because she didn't give enough time to form the subcutaneous tissue storage, which will take about 8 to 12 hours. Okay. And once a patch is applied, the duration of action is for 72 hours or 3 days. So transdermal fentanyl patch, you have to remove it or replace it every 3rd day. And another thing is that when you apply the fentanyl patch, you should not shave the area, because shaving can produce microabrasion, which can increase the absorption, and even temperature can increase the absorption. If the patient has fever, that is going to increase the absorption. If the patient is going to cook, that heat can also increase the absorption. So you have to give some advice to the patient while you advise the patient to take apply fentanyl patch. Don't go near to the kitchen. Don't cook, because temperature is going to increase the absorption. Don't take hot bath. Don't shave the area when you apply the fentanyl patch. Okay. And another important thing is transdermal fentanyl patch is not suitable for patients with unstable pain. That means patients whose pain is suddenly going up, then suddenly going down. This cycle is continuing. We can't predict when it is going to increase, when it is going to reduce. So in such patients where there is no control of pain, transdermal fentanyl patch should not be used. Okay, there are 3 types of preparations of fentanyl is available: injection, transdermal fentanyl patch, and oral transmucosal fentanyl citrate. That is like a lollipop, which can be rubbed over the buccal mucosa and which will give you immediate pain relief. And if you want to convert a patient from oral morphine to fentanyl patch, this is the formula that you have to remember. 60 milligram of oral morphine equivalent per day is equal to 25 microgram per hour fentanyl patch. So that means fentanyl is 100 times more potent than morphine. That's how this 60 milligram becomes equal to 25 microgram per hour patch. And 120 milligram oral morphine would be equal to what would be the strength of
50 microgram.
Yeah, it would be 50 microgram per hour fentanyl patch. Okay, now we have another patient who is complaining of throbbing pain on right front of chest due to carcinoma of the lung. So cancer of the lung producing severe throbbing pain on right front of chest, not severe, it is 5/10. And he is also a non-epileptic and he is on levetiracetam 500 milligram daily. How will you manage his pain? Anybody? What is the severity of the pain here? Mild, moderate, or severe? Which one?
It's a moderate pain, sir.
Moderate pain. So which step of WHO analgesic ladder do we need to use here?
Second step.
Yeah, second step.
So
First step
mild
is
opioid.
yes. First step is to treat mild pain. Second step is to treat moderate pain. And third step is to treat severe pain. So we have to use second step. So
Weak
which
opioid, sir. Tramadol can be tried, sir.
tramadol. Yeah. Okay. Anybody else has any difference in opinion?
Codeine,
Codeine. Why codeine?
it is mild opioid.
Yeah, tramadol is also weak opioid. Codeine is
Weak
another
opioid.
weak opioid.
Acetaminophen.
Acetaminophen is a non-opioid, isn't it?
No.
In the WHO analytic data, it says, second step says you have to use opioids for treating mild to moderate pain. That is either tramadol, tapentadol, codeine, or dextropropoxine, plus or minus non-opioid. That means if you want, you can use, if there is indication, you can use non-opioid. Then again, plus or minus adjuvant. If there is indication, use adjuvant. If not, don't use adjuvant or non-opioid. But we have to use an opioid to treat mild to moderate pain. So here, usually it is tramadol. But there are something which you need to understand about tramadol. Tramadol has dual mechanism action. That means it acts like any other opioids on opioid receptors. But it also acts like a tricyclic antidepressant. What is the example of tricyclic antidepressant? Anybody? Example of tricyclic antidepressant?
Imipramine, sir.
Amitriptyline.
Yes, both are tricyclic antidepressant. Amitriptyline, imipramine, nortriptyline, desipramine, all those are tricyclic antidepressant. Do you know its action? It inhibits the reuptake of noradrenaline and serotonin. Okay, that's what tricyclic action means. And maximum dose of tramadol recommended is 400 milligram per day. But tramadol has another problem. It reduces the seizure threshold. That means it can produce seizure in predisposed individuals. And when you give injection tramadol, don't give fast IV push, which can also precipitate seizure. So give it very slowly. And if patient has epilepsy or patient has brain metastasis, all these are conditions where the seizure threshold is less. In such patients, you should not use, or as far as possible, you should avoid tramadol. Okay, so this is something which you have to keep in your mind while you administer tramadol. So for this patient, tramadol may not be a good choice as this patient has already epilepsy. So you have to use, you can even use morphine, small dose of morphine, maybe 2.5 milligram. I just wanted to tell you tramadol may not be a good choice for patients who is non-epileptic or patients who has reduced seizure threshold like brain metastasis. Okay. So opioids, what are opioids? Opioids, a medicine to become opioids, it should have two properties. One is that it should act by combining with opioid receptors. So opioids acts on opioid receptors and its action is antagonized by naloxone, or in other words, the antidote for opioids is naloxone. And there are three opioid receptors, mu, kappa, and delta. And the opioids which are acting on mu are the potent opioids. And most of the opioids that we talked about are mu agonist. And this classification is based on the opioid classification is based on the interaction at the receptor level. So opioids can be classified into agonist, antagonist, and agonist. Agonist means it attaches to the opioid receptors to produce physiological action. So physiological action would include pain relief, constipation, nausea, vomiting. All those are physiological action of an opioid agonist. And examples of agonist include tramadol, codeine, tapentadol, morphine, fentanyl, methadone. All those are agonist opioids. What is an example of antagonist opioid? It is naloxone. So if somebody comes with opioid poisoning, then you have to administer antagonist, that is naloxone. Agonist antagonist means this group of opioids acts on a receptor as agonist, whereas it acts as antagonist on another receptor. So it has a mixed, it acts both ways. It acts as an agonist as well as an antagonist. And examples of agonist and antagonist are pentazocine, that is Podvin. Many of you might have given to patient pentazocine, and buprenorphine. Okay. Now we have a patient, 70-year-old man, who is complaining of who has carcinoma of the lung and complaining of neuropathic pain on the right upper limb due to nerve infiltration. He is on morphine 10 mg every 4 hourly, amitriptyline 75 mg, pregabalin 150 mg BD. And this patient attends your clinic with delirium, myoclonus, and doesn't have satisfactory pain relief. So this patient on 10 mg of morphine every 4 hourly, amitriptyline 75 mg, and pregabalin 150 mg. And he has delirium and myoclonic jerks, and there is no satisfactory pain relief. So how will you manage this patient? And this is the situation where you can use methadone. Okay. So methadone is different from other opioids. And you can see methadone acts on all the opioid receptors. Whereas morphine, fentanyl, they act on mu opioid receptors, whereas methadone acts on all the opioid receptors. And it also acts like an NMDA antagonist. NMDA antagonist means N-methyl D-aspartate antagonist. Any of you know any other NMDA antagonist? This is usually used in operation theater. Which is that medication?
Ketamine, sir.
Yes, ketamine. Very good. NMDA antagonist. Another example of NMDA antagonist is ketamine, which is useful to treat neuropathic pain. Okay. So methadone has it acts like any other. It acts on all the opioid receptors. It acts as an NMDA antagonist, and it also inhibits the reuptake of noradrenaline and serotonin. Which group of medication has this type of action? We talked about this. This is tricyclic antidepressant-like action. Okay. So you can see for methadone, there are 3 mechanisms of action. And this is beneficial in treating many types of pain which are refractory to other opioids. But there is another serious side effects for methadone. It acts on something called human either agogo related gene channel. Okay. And when it acts on this HERG, it increases the QT interval and it produces some serious arrhythmias. Can you name that serious arrhythmia?
Premature ventricular contraction, sir.
It causes something called Torsades points. Any of you have heard about Torsades points? Okay, which can cause sudden death. So that is one of the serious side effect of methadone. And methadone, once you administer, it will take about 5 to 7 days to get the blood level stabilized and to provide proper continuous pain relief. It is because you can see that when a methadone is administered for the first time, if you are going to start methadone for a patient, the administered methadone will go into the tissue binding sites. So for the first 2 to 4 hours, it will be there in the blood. But immediately after that, it will all go into the tissue binding sites. And once this tissue binding sites are saturated, then only portion of methadone will get detached from the tissue binding sites and will be liberated into the systemic circulation. So for the tissue binding sites to get saturated, it will take about 5 to 7 days. So the most important thing about methadone is before you increase the dose of methadone, you have to wait for 5 to 7 days. But in case of morphine, you can increase the dose every day. Every 24 hours, you can increase the dose of morphine. Whereas in case of methadone, you have to wait for 5 to 7 days. This is one of the most important point about methadone. And like morphine, a methadone is metabolized in liver by cytochrome P enzymes. Okay. And cytochrome P enzyme, many other medications are also metabolized by cytochrome P enzyme. So there would be a lot of drug interactions. That is another important point about methadone. Lot of drug interaction which you would be careful while you prescribe methadone to a patient, because many of the patient would be on many medications which is metabolized through cytochrome P enzyme. And if any of you are interested to know more about methadone, there is a this is free journal which you can access from internet. This is Indian Journal of Palliative Care. They have come up with a supplement on methadone alone. And this is another paper which might give you more information about methadone. So when would you use methadone? That's another important thing. If the patient has opioid toxicities, that means if the patient has, suppose the patient is on morphine, fentanyl, or a tramadol, or any other opioids, and it produces toxic effects like delirium, myoclonus, extreme drowsiness, etc. Then if the patient has complex neuropathic pain, if the patient has opioid-induced hyperalgesia or tolerance, some patients might, when you increase the dose of an opioid like morphine, you should get pain relief. But in some patients, instead of pain relief, they will have more pain. That is known as opioid-induced hyperalgesia. And some patients, they may develop tolerance to opioids. That means to get the same pain relief, you have to increase the dose of opioid. Previously, the patient was taking 5 milligram, and after 1 month, the patient might need to take 100 milligram of morphine every 4 hours to get the same pain relief, which is known as opioid tolerance. So these are the indications to start methadone. And patients who has chronic kidney disease with severe pain. We know that in chronic kidney disease, morphine which gets accumulated and it produces neurotoxicities. So methadone would be a choice in such patients. And allergy to other opioids. Some patients might develop anaphylactic reactions to morphine or fentanyl or any other opioids. In such patients, you can use methadone. And what is the dose of methadone we can use? Patients who are not taking any opioids, in such patients, we can use methadone from 2 to 7.5 milligram per day. And if the patient is taking less than 60 milligram of oral morphine per day, this is in opioid naive patient, it is 2 to 7.5 milligram. If the patient is taking morphine between 60 to 199 milligram, and if the patient is less than 65 years, then we have to use a conversion ratio of 10:1. That means if the patient is taking 100 milligram of oral morphine per day, what would be the methadone dosage in such patient? 100 milligram. Patient is taking 100 milligram per day oral morphine. What would be the methadone dose?
10 milligram, sir.
Yeah, can you explain, Kurandavel, how did you get 10 milligram?
Since it is 10:1, sir.
Yes. So 100 divided by 10. So that is 10 milligram. If the patient is taking more than 200 milligram of oral morphine, or if the patient is more than 65 years, the conversion ratio is 10:1. Suppose the patient is taking 250 milligram of oral morphine. What would be the methadone dose? $250 divided by 20. Okay, that is
12.5 milligram, sir.
Yeah, 12.5 milligram. Okay. So regarding methadone, these are the important points that you have to consider. There are a lot of drug interactions. And you have to wait for 5 to 7 days before you increase the dose of methadone. And it is not like any other medication because the potency of methadone varies depending on the dose of morphine. This is the methadone available in India as tablet as well as syrup. Okay, now we'll move on to adverse effects of opioids in general. So what are the adverse effects? We can divide it into two: side effects and toxic effects. So what are side effects? Side effects are those adverse effects with therapeutic doses of opioids. So can you tell me what are the side effects of opioids?
Vomiting, nausea, constipation.
Anything else? Constipation, nausea, vomiting, sleepiness and tiredness,
Drowsiness.
itching, dry mouth, urinary hesitancy. So the first three are the common side effects: constipation, nausea, vomiting, sleepiness and tiredness. Whereas the next three are not very common, but can present in some patients: itching, dry mouth and urinary hesitancy. Constipation. This is the most common side effect of opioid. Okay. Many of you might be teaching the students, and if you look at the pharmacology textbook, the most important side effect would be written as respiratory depression. That is not true. That is not the most common side effect. Most common side effect is constipation. It occurs in almost all patients. You can see 95% of patients would have constipation, and it will continue to be there as long as the patient is on opioid. So, whenever you start a patient on opioid, you have to prescribe something called stimulant laxative. It is not any laxative, it is called stimulant laxative. Stimulant laxative means it is laxative as well as it increases the peristalsis. Okay. So example is disacodyl, senna, sodium pycosulfate. Then nausea and vomiting. It is due to stimulation of chemoreceptor trigger zone in the brain. Okay, CTZ. It is due to stimulation of CTZ in the brain. And this occurs almost in 1/3 of the patient. That means about 30% of patients on initiation of opioids can have nausea and vomiting. But compared to constipation, nausea and vomiting is self-limiting. So the patient can have nausea and vomiting for first 3 to 5 days. After that, it will be self-limiting. So for the first 3 to 5 days, you have to use an antiemetic. And this is something to block receptors in CTZ. And in CTZ, there are dopaminergic type 2 receptors, D2 receptors. And that's why you use haloperidol and metoclopramide to block these receptors on chemoreceptor trigger zone. And sleepiness and tiredness, again, this is self-limiting. You need not do anything. Toxic effects. So adverse effects was divided into side effect and toxic effect. Toxic effects means these are the adverse effects when you administer more than the required dose. Suppose a patient requires only 10 milligram. You are giving 20 milligram. That can produce some adverse effects which are known as toxic effects. And this is manifested by delirium. What is delirium?
Loading of consciousness, sir.
Okay. In simple words, suppose if you want to ask the caregiver, what would you ask?
Poor concentration, sir.
Okay. So there are many features of delirium, but you can ask the person, is he speaking relevantly? Okay. Or irrelevantly. Delirium, then myoclonus or myoclonic jerks, that is jerky movement of any part of the body, and extreme drowsiness. So these are the manifestations with which you know that the patient has toxic effect or not. Okay, some of you have been talking about respiratory depression. So how common is respiratory depression? It is extremely rare. Okay. And this is a systematic review from 2003, which says many of the patients takes their medication orally, and usually the oral medications are increased in a titrated fashion, which ensures that respiratory depression is unusual. And if the patient has respiratory compromise, then we should see whether this patient has pneumonia or pulmonary embolism or cardiomyopathy, or are we co-administering another medication like benzodiazepine. So you have to understand that the respiratory depression is very, very unusual with oral morphine. I have not seen even a patient with respiratory depression in the last 20 years of my career in palliative care. And I have prescribed thousands of patients with morphine, fentanyl, and methadone, both injectable as well as oral medications. And this would be another concern, isn't it? Opioids causing addiction. How common it is? Anybody? So I would ask another question. How many of you take coffee or tea in the morning? I'm sure many of you would take. Suppose one day you do not get coffee or tea in the morning because there is no coffee powder and sugar at your home. How would your body react to it? What would be the manifestation of not taking coffee or tea in the morning?
Headache.
Headache, yes. Very good. What else?
Irritable.
Yes, irritation. Very good. Next. Yawning, isn't it? So, why these symptoms?
Since it's habitual, sir.
Huh?
Habitual.
Habitual. Anybody else?
Addicted to coffee or
Yes.
tea.
Very good, Agnes. Addicted to coffee and tea or caffeine, isn't it? So, this is not addiction. This is called physical dependence. Okay. Whereas addiction is psychological dependence. If you have psychological dependence, then you will break into the next house where coffee powder and sugar has kept, and then you will make coffee and drink it. That is addiction. Or addiction is called psychological dependence. Whereas your body is expressing some symptoms like headache, irritation, yawning, and because you have been giving caffeine for the last 30, 40 years, and suddenly you are stopping it. So your body is reacting to it, which is known as physical dependence. And this is not same as psychological dependence. If you have psychological dependence, then you will break into the neighbor's home where coffee powder and sugar has kept. So just understand the difference. So opioids can produce addiction, but if it is used for medical indication, then the chance of addiction is very low. And I would also like to give you, just see this, the comparative prices of opioids. Suppose a patient is taking morphine 5 milligram every 4 hourly. The patient needs to spend about 3 rupees 50 paise per day. To get the same pain relief, this patient needs to take 300 milligram of tramadol, which would cost anywhere between 24 rupees to 50 rupees. And to get the same pain relief with the fentanyl patch, the patient has to spend 250 to 400 rupees. And there is something called buprenorphine patch. If that is being used, it is 1920 rupees. And if you use methadone, it is 4 rupees 50 paise. So look at the comparison. We can give pain relief with various medication. And the cost, it is from 3 or 4 rupees to 2000 rupees. So this is where we need to be aware about the price of different medication, because many of the patients would be very poor, and if we ask them to take buprenorphine patch or fentanyl patch, then probably they may not be taking it, or they may have to sell all their properties to take this. So pharmacoeconomics is very, very important. So thank you. That's about opioids. And if you want to ask any questions, please.
Participants, if you have any questions, you can post it in the chat box, or either you can unmute yourself and ask.
Anybody?
I think there are no more questions. We can wind up today's session. Thank you, Dr. Sunilkumar, for the wonderful session. Thank you all for joining today's session. Thank you. Let's see you in the next session. Bye.
Thank you. Thank you, everybody.